A lot of the recommendations really had to do with working across systems. Which perhaps will be some of the most difficult to implement. What do you, we've seen prior governors really take a kind of hard-nosed approach and not really accomplish much. What do you think will be the administration's, assuming that they continue in power, what do you think there will be their approach to working across systems?
We've gotten a lot of support. Like I said, I mean, the governor himself, the lieutenant governor, have been very involved. The director of community health sits in every one of these, meetings himself. He doesn't send a designee. He sits on the commission himself. And so there's a lot of investment, I think, by the administration, certainly in what we've done so far. And the question about working across departments and agencies and frankly even across programs was one of the first really obvious barriers that came up in our conversations. And there was this amazing aha moment. It might have been our second or third meeting of the whole full commission before we went out to do any of the public hearings. They asked each department and agency of state government to send one person to the commission and to talk to us about what they are already doing for this population. And it was everybody from state police to DNR to the ones you'd normally sort of think of, community health and human services. But literally our Michigan Works Agency, the employment agency, literally every agency came and started talking. And even, like I said, DNR, which a lot of us didn't know. We actually run programs in some of our state parks and state forests to help run camps so that our kids with mental illness or developmental disabilities can get out and enjoy our park system, and that we actually have more parks in our state that are accessible for people with disabilities than any other state in the nation. We had no idea, and we're the only ones in the nation that have an accessible waterfall. Quamanon Waterfall is is completely physically accessible, which is neat to hear. But as we went around the room and people talked about what their agency was doing or their department was already doing for this population, watched people go, wait, wow, you're doing that? Or what, you had that? I had no idea. Like, they didn't even know. The right and left hand had no idea what all we were doing. And one really stunning example, so in my work group, veterans issues fell into my work group. As we ran around the room, the new Veterans Administration agency had 675 long-term supported housing vouchers from HUD for veterans that are returning that have, again, either anxiety, depression, PTSD, some kind of even short-term, maybe curable condition. And MISHDA, our housing agency, had no idea, and we're like, they weren't talking to each other. So MISHDA knew who some of the veterans were who needed to use these vouchers. They didn't know that the Veterans Administration Agency had vouchers that they could use, and it was like just being in that room together helped break down some of those silos. But that's one of the biggest problems I think that we have for the programs that we either fully fund or mostly fund in partnership with the federal government. There's not a lot of coordination, and you watch some of these citizens will be in programs that we fund for much of their life, and it might start with special education, and maybe they're in foster care, maybe they end up somehow on Medicaid and get their health care support through us, maybe they're get services at a CMH, maybe somebody ends up in a corrections system. But right now the information is, they're not talking to each other. We don't have standardized criteria, and you see in the recommendations, like standardizing some of the information that we collect and gather is really important, because we heard people tell stories, and again, every single one of these recommendations came from somebody's real story. Somebody who's been incarcerated, whether in our local jails or in one of the state prisons, has had a diagnosis, has been on a treatment plan, on medication for whatever number of, let's say, 5 years, gets out. They are referred to their local community mental health agency. Their diagnosis doesn't follow them. Their prescriptions don't follow them. They have to start all over again with an evaluation, with a diagnosis, and it just finding a way, again, respecting people's individual right of privacy, respecting their ability to self-determine. But if we had a a mental health in particular, but a healthcare passport that would follow them with their own login and password to at least be able to share that information. If we standardized evaluations, if we standardized the criteria for people to be able to work in these programs agency by agency, instead of saying, so as you all get your MSW, some programs and MSW will, you can provide all kinds of care in community mental health. But DHS didn't have the same requirements, and corrections didn't have the same requirements. And so a lot of the standardization, so that the credential that you have, you'll be able to do the same work for the state in any agency if it's similar work and your credential is what's needed. Right now, that's not the case. It's just really, again, low-hanging fruit kind of stuff that just makes no sense, but needs to be fixed. So I think there will be a lot of willingness to work across departments. The biggest challenge is really going to be, how do we break down the funding silos? Because it's more about the funding than anything else, and helping the funding follow the individual, and particularly in the area of veterans. So we've got a lot of veterans that come back from, especially right now in Michigan, a lot of folks who've been deployed who come back, even if they are willing to acknowledge that they need mental health care, because in that particular population it's a little bit harder to, I think, than even the general public to admit that you have a concern like that, and they have a different set of fears, right? If they want to stay in service, or they want to be in some other kind of law enforcement someday, you can lose your security clearances based on what your diagnosis is. You can lose your access to carry a concealed weapon, and guns tend to be a little more important in this population than some populations. So if we have a veteran returning home who acknowledges that they need care, there cannot be a wrong door wherever they end up. If they end up at community mental health, if they end up at the VA, if they end up in a local, either an advocacy organization or their doctor's office, the money has to follow them. We can't turn them away. And this is happening in our state every day right now. Veteran goes to the VA, and the definition of veteran, we have to standardize the definition of veteran, because different programs have different definitions, and maybe if you're not deployed during a particular time to a particular theater, then you might not be covered in the state for certain things. And so I think you'll see a lot of interest in working across departments. We just have to figure out how to make the funding flow so that people feel comfortable,